hypotension, anaerobic metabolism, and evidence of hemodynamic criteria which are consistent with having a low cardiac output state. And the mortality for patients with cardiogenic shock is remarkably high. All patients going into cardiogenic shock have at best a 40 to 50% survival. This is a very severe problem when it happens. What sort of patients will we be looking at for post-cardiac surgery problems? Well, first of all, we have those who are completely reversible, potentially, who just have a stunned myocardium, potentially from inadequate protection or maybe a little bit of air down the coronaries, to those who are potentially reversible with myocardial infarctions or acute pulmonary hypertension from whatever cause. And then there are those who have an irreversible problem, either due to this being an insult which is on top of severe existing ventricular dysfunction, myocardial infarctions, etc. What do we need to look at? Sorry, the projection of this isn't great, but we're looking at patients fundamentally who are hypotensive following CPB, and that can be due to a low cardiac output state or low peripheral vascular resistance.
The session is starting, so can we go back, please? The session started.
If, of course, if the peripheral vascular resistance is very low, then it's a combination of fluids and vasopressors. And low cardiac output state, clearly heart rate needs to be addressed, contractility needs to be addressed, preload needs to be addressed, basic inotropy needs to be commenced, all before you need to start thinking about VII ECMO. So let's look at the alternative therapies that are available. First of all, inotropic therapy. Inotropes are difficult. They're all we have in terms of the chemical makeup. We have a range of drugs available. None of them have been shown to be beneficial to patients, and many of them have been shown to actively increase mortality, particularly adrenaline, particularly vasopressin, particularly dobutamine. So they've been clearly demonstrated recurrently, but they are all that we have, and we are effectively flogging the heart in order to maintain the life in the body. Levosimendan, a novel inotrope, may well be better, although, and this is from recent meta-analysis, it just pipped past the post in a direct comparison with dobutamine. And the data is far from convincing that levosimendan is better. In theory, it potentially could be, because you're looking at a drug that doesn't increase myocardial oxygen demand. What are people doing around the world? First of all, they're looking at, if we look at mechanical support, the top line is balloon pumps. This is prior to Thiel's study in 2011. You can see it's a fairly high level of balloon pump use for patients in cardiogenic shock. But we've seen over the last 10 years a progressive rise in short-term and medium-term mechanical support. And I think it's important that when we're looking at short-term mechanical support, whether that's ECMO or a VAD, we really need to be thinking about what is the solution for this patient, what is the access to this for this patient to ongoing mechanical support. If there is no option for a VAD, if there is no option for transplantation, we need to think very carefully about what our goals of therapy are. The different tools that we have at our disposal provide different levels of support, different physiological benefits to each patient. So, for example, the balloon pump reduces afterload, whereas ECMO, particularly peripheral ECMO, increases afterload. Coronary perfusion is broadly unknown. Preload can certainly be reduced in patients on ECMO as we're taking blood from the right side of the circulation directly to the left, etc. The tools that we have, there's no direct studies, but let's look at the Thiel's study from 2012, which looked at cardiogenic shock post-myocardial infarction. 40% mortality at 30 days, 50% mortality at a year. No difference between the two groups. And although it certainly improves the physiology, it's difficult to say that it definitely improves outcome. And the same is true of the impeller. Limited numbers of studies have been done, consistently demonstrating that it improves cardiac output, consistently demonstrating that lactate comes down. But again, and this is a trial of impeller versus balloon pumping, difficult to say that there's any actual survival advantage for patients. For ECMO, of course, we have two fundamental types. We have peripheral ECMO or central ECMO. The surgeons among you will have your clear preferences. What's interesting is that several of the surgeons we work with now are moving towards using peripheral ECMO as their post-cardiotomy tool of choice rather than central. So they're getting the chest closed, getting hemostasis, running heparin-free in that early post-operative period, and using peripheral ECMO as the bridge, which is an interesting approach, and that's been starting to sneak in over the last little while. If we look at a comparison for ECMO in general in cardiogenic shock, there is incredibly limited data. Now, less than 100 patients have had a head-to-head ECMO versus balloon pump, although on the limited data ECMO appears better, and similar numbers have had ECMO versus impeller or tandem heart without any obvious difference. However, the data is incredibly poor and incredibly limited in terms of helping guide us in our decision making. Overall, the outcomes for VA ECMO vary dependent upon what is wrong with you. So, difficult to see here, but myocardial infarction, you're expecting somewhere around 40 to 50% survival. Myocarditis does the best of all, 60, 70, 80% survival in some series. Chronic decompensated or acutely decompensated chronic cardiomyopathy depends on your access to downstream therapies. Septic shock can be up to 70 or 80% survival, and post-cardiotomy is routinely somewhere between 10, 20, 30% survival. But again, it depends very much on the access to downstream therapy. What are the things that determine your outcome? Well, the key, in my mind, is time. Now, if you look at these factors, over on the left you've got lactate, so a higher lactate, worse outcome. In the middle you've got pH and creatinine, a lower pH and a higher creatinine, worse outcome consistently. And that really is a marker of time in cardiogenic shock. If you do what most of us do, which is let's give it a few more hours and see what happens, the patient inevitably will die. Age is also incredibly important. The older you are, the more likely you are to die. There have been a number of scoring systems developed, and they are including post-cardiotomy VA ECMO, but they are only validated in groups where ECMO has already been decided, so they're not that helpful for helping your decision making. But if we look at the groups who do very well, myocarditis, refractory VF do incredibly well. Cardiogenic, post-cardiotomy, not so well. Diagnostics aside, younger patients do better. Patients who are of a normal weight do better. So the cachectic and the overweight do very poorly. Patients with significant liver, renal, CNS dysfunction do very badly. Duration prior to the commencement of ECMO. Getting in there under 10 hours is clearly associated with benefit for these patients, as are their initial mortality. And if you look at the SAVE score as it gradually rises, you get a progressive rise in outcome, an improvement in mortality. And really what you want is a SAVE score of 0 to 10. What's missing in the SAVE is lactate, and lactate's been consistently associated with improved as being associated with mortality, where survivors have a lower pre-ECMO lactate than non-survivors. And that's been put into another scoring system, the ENCOURAGE. These are gradually coming out, which looks at, amongst other things, lactate, renal function, age, weight, etc. And a low ENCOURAGE score gives you a much, much, much better outcome than a high ENCOURAGE score. And this is 100% survival, near 100% survival at the top to nothing at the bottom. So, there are a number of approaches out there in the literature at the moment in terms of how to address these patients. The first is accepting the diagnosis of cardiogenic shock, accepting that the patient's not got a poor urine output because they've got a degree of chronic renal failure, having an open mind, excluding your surgically correctable problems. Is there a localized posterior effusion which is causing a degree of subclinical tamponade? And actually the best thing to do is to take the patient back to theatre. Has the graft got a problem? Do you need to go to the lab? Do you need to get a stent? Do you need to go back to theatre? So keep an open mind. Patients will always confound you. Think about, and this is the Melbourne group's criteria, think about ECMO very early on. Once you're on a moderate amount of inotropes and vasopressors. In the Melbourne group, they use 0.3 mics per kilo per minute of adrenaline equipment, so not a huge dose. Think about once you're on looking at your second inotrope. We know that the addition of a second inotrope is associated with a massive increase in mortality in the post-cardiotomy population. Think about the patients that you're thinking about putting a balloon into. Also look at the patients with inadequate organ support. Look at your hepatic impairment, look at your renal impairment. Oligoanuria is not necessarily part of the standard SIRS response. Look at their hypoperfusion, their lactate, and obviously dysrhythmias. Using that approach, the Melbourne group have a nearly 60% discharge home alive, neurologically intact. Another approach, which I'm quite fond of, is this one, which was published a few years ago, which is take the patients in cardiogenic shock and get a balloon in. We know that a balloon won't necessarily improve the health of a population, but it may help individuals. And if what they did was they started with a balloon and then after 1 hour, if things had not resolved, they moved rapidly over to ECMO. This is to try to better characterise the population. And in their hands, they moved from a 25% survival to a nearly 60% survival. So it's very important to keep an open mind and to look at different modalities of support for an individual patient. You also need access to alternative therapies. And in this case, you can see at the top the survival with access to a VII transplant program versus survival without access to the same VII transplant program. So how do we think about it? We tend to think about it as give them 10 to 12 hours, get the fluid right, get the inotropes right, get them rewarmed, do the simple things well, but don't sit on them all night. Don't say, it'll be fine in another 12 hours. Sit there and watch them. Do the basic things first, get the inotropes on, etc., get the rhythm right, the rate right, make sure your pacing's right, AV sequential pacing ideally if you can. Get them onto VA, but don't stop there. Move straight to investigation. What is wrong with the patient? Why won't they come off? Is there a problem with the surgery? Is there a collection you've missed? Get an echo, get a cardiac cath early on all these patients. Don't say to yourself, I'm sure that the grafts are fine. I'm sure that the arteries are fine. Move straight on. Keep that open mind and say, let's just exclude it as being a problem. We need to think about decompressive strategies. Then we need to think about recovery and options prior to palliation. I've got a few minutes left, I think, 5. Perfect. We're going to talk a little bit about some of the aims of management and the concepts of the way we run VA, and it's very similar to VV in terms of the overall aim. So first of all, rest the heart, rest the lungs. You're in a position that you're able to rest them. Don't keep flogging them with inotropes. You don't need to. Figure out what on earth is going on, give adequate support for the body and avoid complications. When we're talking about adequate support, we're thinking of two things. We're talking about delivery. And of course, in oxygen delivery, your cardiac output is a combination of your native and your ECMO. So get your access right, get your which is equivalent of your preload, your afterload right, and your pump flow. Have enough oxygen content, give yourself enough hemoglobin to work with, and get the venous sats down above 60 and your lactates down rapidly. Don't necessarily aim for too high a blood pressure. So we would tend to aim for a MAP of 55 to 60, but we also use cerebral oximetry in order to try to optimise cerebral blood flow on the basis that that's the most important part for any individual patient. manipulate your oxygen delivery, improve your content, optimize your blood flow, decrease your afterload, and if you're still struggling, look at utilization. Look at temperature control, look at shivering, look at movement, look at distress, and get those under control. If really necessary, paralyze the patient. This is also what you want. You want a patient who has some ejection. You can see here the valves are opening and closing. There's not a lot of movement in the heart, but there is a little bit. What you don't want is this, a significant left ventricular thrombus. You want to avoid that at all costs. So how can you avoid that? Levosimendan has been shown in a small study, only 6 in the Levosimendan group, to improve the ability to wean. So maybe Levosimendan, not increasing cardiac workload. Balloon pump, potentially. It does have physiological effects, even when on ECMO, in terms of improving your pulmonary capillary wedge pressure, improving your forward flow through the heart. And in fact, combined with VII ECMO, it appears to improve outcome from a very recent study from this year. You also, when we're thinking about stasis, need to think about other ways of decompressing the heart. So the big problem with ECMO is, of course, the increased afterload, the decreased left ventricular ejection fraction. And here what you can see is they've put a transseptal puncture, they've popped a small cannula through the right, through the atrial septum, down through the left atrium and into the left ventricle in order to decompress the heart better. And they've had this sort of impact on the chest X-ray, going from a complete whiteout to improved. So we do need to think about our strategies for decompressing the heart. We also need to think very carefully about our strategies for managing the improving heart. Particularly the Harlequin syndrome, where you've got heart ejecting deoxygenated blood because the lungs are yet to recover. Clearly, the first thing to do is to look at your increased ventilation. If that's not possible, you need to think about moving over to VII ECMO. In order to look after your patient, monitoring is key. And we spend a lot of our time making sure that the monitoring is right for patients.
1 minute.
You often don't have a pulsatile circulation, so we use NIRS, both cerebrally and on the foot, and we have a schema for our nurses to follow. Finally, when do we start weaning? Well, this is some data from the French group, and they're looking at markers of echocardiographic markers to assist with weaning. Aortic VTI, pulse pressure, and ejection fraction. And as those improve, particularly aortic VTI and ejection fraction, we see a steady improvement in the weanability. And we would tend to go down to low flow for about half an hour or so, down to a litre of pump flow, in order to assess the patient, both echocardiographically and in terms of their biochemistry, lactate, SATs, etc. Thank you very much.
Thank you very much. Thank you, Dr. Parrott. Now we proceed with our next distinguished guest speaker, Professor Raul Gazamori, Professor of Medicine, Professor of Physiology and Basic Sciences, have been taking part of, for a long time, developing resuscitation guidelines, reviewing resuscitation guidelines, and updating them according with the American Heart Association. And just a quick reminder again, please switch your mobiles to silent while here. Thank you very much.
Use that one. Okay. Thank you so much. Thank you so much. This is my first time in the Middle East and in Kuwait, and I want to thank you, the organizer of this event. So far has been wonderful. I have learned a lot from the other speakers. And the topic I'm going to discuss today is more practical. I'm an intensivist. I do some research, but I spend time at the bedside taking care of patients. So I want to give you sort of an overall approach to a patient who is in circulatory shock that we see at the bedside. So the first question that I want to ask or attempt to address is, what do we mean with circulatory shock? And the definition I want to offer you is of a clinical syndrome that results from a sustained failure to deliver the oxygen that is needed to meet the metabolic demands of tissues consequent to a macro or micro circulatory abnormalities. And I want to emphasize the importance of being in a clinical syndrome because people who are taking care of patients have a responsibility to identify that condition, and the nurses plays a very important role in the diagnosis. It's important to realize that it's not a transient event, but it's something that lasts in time, and that the core of the syndrome is the inability of the oxygen to meet the metabolic demands of the tissues. And again, we will see that we have different mechanisms by which a patient develops circulatory shock, and continued on the mechanism, the treatment is going to vary significantly. So what is at the core of this clinical syndrome? And it's oxygen. And I wanted to just go back for a few minutes to the very basic pathophysiology of why oxygen is so important and why oxygen, in a way, drives a lot of the things that we do in critical care. Of course, oxygen is required at the mitochondrial level, and this is for microscopy, electron microscopy of the heart of a rat, showing mitochondria. And if we zoom into one mitochondria or mitochondrium, we're going to recognize some interesting structures here. One is the outer mitochondrial membrane, and the other one is the inner mitochondrial membrane. And in the inner mitochondrial membrane, we have this protein embedded in, which we call it the electron transport complexes, which essentially are proton pumps that pump proton from the matrix to the intermitochondrial membrane to establish a proton gradient that drives this enzyme, the ATP synthase, which is responsible of regenerating ATP from ADP and inorganic phosphate. So the energy that drives these pumps comes from nutrients that are metabolized in the Krebs cycle, and the release of electrons and the transport of these electrons allow this process to continue. And what the oxygen does basically takes those electrons away and enable this electron flow to continue forever until we die. So the absence of oxygen essentially is going to clog the system and preclude the proton pumps to build this gradient through which we generate ATP. And when that happens, then glycolysis becomes a very ineffective means to generate ATP through anaerobic metabolism. And what happens is then the glycolysis goes to the end product of lactate. But it's very inefficient. For 1 mole of glucose, through the aerobic metabolism, we generate 32 ATPs, whereas through the anaerobic pathway, only 2. Now, why this is important? Because the lactate diffuses across cell membrane, and we can measure it in the bloodstream. So the lactate is indeed a very good metabolic marker of this inadequate delivery of oxygen or utilization of oxygen, as we have learned throughout today. Now, I wanted to bring to this discussion who was my mentor, Dr. Max Harry Weil, who died in 2011, and he was one of the pioneers of critical care medicine. He was the one who thought that having critically ill patients clustered in one area will help them survive by bringing resources together. He did many things, and one of them was to consider lactate as a marker of the severity of circulatory shock. And indeed, it was him who published many years back in a paper in Circulation in 1970, the famous relationship between survival and the initial lactate when a patient who is critically ill comes to the intensive care unit. And you can see here that in general, if the lactate is less than 3 millimoles per liter, there's a very good probability that that patient who has a clinical syndrome of circulatory shock is going to make it from the ICU. But as the lactate increases at the beginning of the disease process, the probability is less. However, that's not the end of the story. And it depends a lot of our action and how effective we are in managing this situation and bringing the lactate down. And this is a study that was published more recently by Dr. Marty in 2013. And what he showed was that even if the lactate was high at the beginning of this disease process, if the lactate came down, there was a good probability that the patient was going to survive and go home. Whereas if we failed to bring the lactate down, it means that we're failing to reverse circulatory shock, and the probability of survival is much, much less. So we do have, among many other things, one simple measure that we can follow at frequent intervals, every 2, every 3 hours, that will tell us whether or not our patient is improving. Now, I wanted to go very briefly through this basic equation that tells you where we can act in order to improve oxygen delivery to the tissues. And probably many of you know this one. I think it's very helpful to remember it and to have it at the bedside. Oxygen delivery is where we're going to act. And oxygen delivery is a function of the cardiac output, as we have discussed repeatedly today, and the arterial oxygen content. The number 10 is there only to adjust for the units of measurement. Now, if we concentrate on the cardiac output, this is a function of the heart rate and the stroke volume. And the stroke volume turn depends on the ejection fraction, which is going to be affected by the stroke volume is going to be a function of the ejection fraction times the end diastolic volume. The end diastolic volume is a variable that we can optimize by improving the preload. And that's one of the reasons why we give fluids to a patient who is in circulatory shock. We want to increase the preload, increase the end diastolic volume, and for the given ejection fraction, we are going to end with a higher stroke volume, and therefore with cardiac output. That's a very simple reason. We also are mindful that contractility might be affected, as we learned today, in patients with sepsis, contractility might be compromised, and for that, we might want to use an inotropic agent. And a heart that has low contractility is also more susceptible to increases in afterload. So all those are parameters that impact the management that we can assess at the bedside and decide what is the best course of action. And in terms of oxygen, it's important to realize that when we look at the arterial oxygen content, it's a function essentially of 2 main factors. One is the hemoglobin that we can measure, of course, and the other one is the oxygen saturation, whereas the partial pressure of oxygen plays a very little role in terms of oxygen being transported, dissolved, is minimal. That's the reason why measuring the pulse oximetry is sufficient. We don't need to measure the partial pressure of oxygen in the blood gas all the time. And with those 2 numbers, we will estimate whether or not our arterial oxygen content is adequate. So in going back to the beginning, these are the parameters that will influence our oxygen delivery. And those are the ones in which we're going to act. Now, going back to history a little bit also, I think it's important to discuss the contribution of Dr. Jeremy Swan and Dr. William Gans, the ones who conceived the concept of the Swan-Gans catheter. And at some point, this was a device that we use a lot at the bedside. Today, because we have many other means to assess the hemodynamics, including ultrasound, echocardiography, we rely less and less in the Swan-Gans catheter. But it's important to recognize that because of this device, this catheter, early on with Dr. Wild and others were able to describe different types of circulatory shocks. And essentially, we recognize 4 forms. One is hypovolemic, in which the cardiac output or the cardiac index is reduced because there is less intravascular volume, like in hemorrhagic shock. And you're going to find with the Swan-Ganz catheter that all the pressures are low. The pulmonary artery occlusive pressure, the pulmonary artery pressure, and the right atrial pressure. We also recognize obstructive shock, in which something opposes mechanically to blood flow, and a perfect example would be a massive pulmonary embolism in which the cardiac index is reduced, but the pulmonary artery occlusive pressure, which reflects what happened to the preload of the left ventricle, is not increased and it might be reduced, whereas the pulmonary artery pressure, because of the obstruction, is increased, and the right atrial pressure as well. Cardiogenic, in this case, an acute myocardial infarction. Again, the cardiac index is reduced because of inadequate left ventricular function, and all the pressure upstream are going to be elevated. And then we have this weird thing, but we call it distributive shock, whose representative, the most common one, is septic shock. And anything can be there. Early on, if we don't treat a patient in septic shock, that patient may have a component of deficit of intravascular volume and may actually present as hypovolemic shock. As we treat the patient typically and we improve after the preload, the patient moves into the hyperdynamic state. What I wanted to emphasize is that the first 3 ones have in common that the core problem is a reduction in cardiac output. And the tissues are, at the beginning of the process, relatively intact. And our purpose in treatment is to improve the cardiac output. When we look at septic shock, it's a very difficult process. And dealing with that requires a different approach. And we can discuss that, although that's not the main purpose of this presentation. So how do we assess adequacy of perfusion? I want to emphasize the importance of the repetitive bedside assessment by nurses, because if somebody has a reduction in cardiac output, the physiological response is to have an increase in peripheral vascular resistance, and that gives clinical signs that can be easily recognized at the bedside. Decreased skin temperature, reduction in capillary refill. There will be a reduction in urine output. So it's very important from that perspective to recognize and alert the team the patient is suffering a state of inadequate perfusion. Very important is to assess the preload. And we can discuss at length how important is this. On the one hand, we want to optimize the preload so that the left ventricle is going to work well as the right ventricle. On the other hand, because the treatment of the preload is to give fluids, we want to avoid excessive amount of fluid that will result in edema. So I'd like to use the concept of optimizing the preload in a patient who is in circulatory shock. And it's very likely that every single state will need some amount of fluid. Now, the specific amount is patient dependent. So I'm not very much in favor of a fixed amount of fluid, even though that is what is being recommended. I like the idea of titrating the amount of fluid in a given patient. And from that perspective, we have made progress by looking at non-invasive technique. And essentially, I'm going to skip through these 2 slides and skip to what I believe to be very important, which is the use of ultrasound at the bedside. It's okay to look at the jugular veins and you can get a lot of information, but I find very useful and not difficult to learn to concentrate on the IVC with bedside ultrasound, with the purpose of increasing the stroke volume and therefore the cardiac output. So here, for example, I don't think I can run the... So here's a case, for example, of a patient who was intravascular volume depleted. And the IVC was very collapsed, and especially more during inspiration. it will collapse close to 67%. This is a situation which identified a fluid responsiveness condition. This is a different situation in which the diameter of IVs is normal, with minimal collapse during inspiration. This patient is not likely to improve with fluid. So the fluid, right now, we have means to titrate and optimize. Now, what about vasopressors? We don't have time to discuss, but I can tell you that we may have a different perspective from my distinguished colleagues. From a clinical perspective, what I see more often is that once the vasopressor is initiated, the team tend to relax and allow the titration of the vasopressor to a target mean aortic pressure. Now, I'm not sure that that's the best way. I think we need to reassess the patient frequently. And it is something that is controversial, but I throw this here just for discussion. I look at the Sepsis 3 document that was published less than a year ago in JAMA. And in Table 3, they look at mortality in relation to 3 conditions: the responsiveness to fluid, the use of a vasopressor agent, and whether or not the lactate was elevated. I rearranged the table, and this is what I found. That when the other conditions are the same, meaning the use of the use of fluid administration, and whether or not the patient remains hypotensive after the fluid, for the same level of lactate, if the patient was on a vasopressor, for the entire group, mortality was worse. Now, I'm not saying that this is cause and effect, but I think this data should give us some pause and ask the question as to whether or not we have to use vasopressor to the level that we use. Now, to finalize my talk, this is what we do in our intensive care unit. We believe in the concept of reassessing the patient frequently. You have 4 conditions here that can lead to circulatory shock: hypovolemic, cardiogenic, obstructive, and distributive. And very often, we have a combination of all of them. And the goal is to stabilize the patient. How we define hemodynamic instability, clinical signs, hemodynamic signs, and elevation in lactate, and if the patient, for whatever reason, is receiving a vasoconstrictive agent. At that point, we need to assess, come up with a plan, institute the plan, and not leave the patient alone. Come back. How often? I don't know. I will say at a minimum 3 hours later. Do exactly the same. In a way, like we do, we run a code. We will check the pulse every 2 minutes. Let's do the same thing for a patient who is in circulatory shock, without forgetting that we have to reassess constantly the underlying condition and don't leave that alone. So that's my last slide, and this is where I come from, an institution that has a university on one side and a hospital that's a combination with a VA hospital for retired military personnel, and active duty. All together, we work there. Thank you.
Thank you very much, Professor Gazamori. Now we proceed with our Dr. Nicholas Barrett again to talk about the evolution of ECMO and the use in the intensive care unit. Please, thank you.
Wonderful. Thank you again. I continue to have no conflicts. We're going to change tack a little bit and move away from the heart and on to the other rather important organ within the thorax, the lungs. You're all very familiar with the original definition of ARDS. You acute respiratory distress syndrome. Looking at those elements, hypoxemia, low wedge pressure, bilateral infiltrate, and acute onset. However, this patient, on 100% oxygen, PO2 of 4 kilopascals, 30 millimeters of mercury, a PF ratio of 4 kilopascals, tiny tidal volumes, on reasonably well-controlled ventilation, is very different to this patient who is on 50% oxygen with reasonable gases. The patient on the left should be dead by the time you finish your shift, and the patient on the right should not. And yet they were lumped together in all of the original ARDS studies. And that led to a change in the definition, the Berlin definition of ARDS, which kept many of the similar elements. So it kept keep it an early onset within a week or so, bilateral opacities, non-cardiac, but then tried to segregate oxygenation into mild, moderate, and severe, with severe being less than 100 millimeters of mercury or less than 13 kilopascals. And we know that overall, outcomes have improved over the years. That's potentially in part due to some of our ventilatory strategies, but also potentially in part due to other approaches that we've taken. We know, however, that they remain very high for the sickest patients. If you have mild ARDS, about 1 in 3 of patients will be dead before they leave hospital. Moderate, about 40%. Severe, nearly half. 50% mortality, or thereabouts, is consistent. And this is from February this year. So this is not old data. These patients are sick, really sick, just like the cardiogenic shock population. And we need to bear that in mind. And this is just based on your PF ratio that you are this sick. And a strategy of different approaches has been suggested. And we're just going to very rapidly run through these different approaches, because ECMO cannot be thought of in isolation. ECMO is a team game, and it is something that we use as part of a lung protective strategy. And without using the rest of the lung protective strategy, you are not going to make your patients any better. We think about low tidal volume, the application of PEEP, neuromuscular blockade, prone positioning, and then finally to ECMO. Standard lung protective ventilation has been with us for not quite 20 years, but not far off it. Bringing the volumes down to 6 mils per kilo, bringing the pressures down below 30. And I guarantee that in both your intensive care and my intensive care today, we're not doing it well. Guaranteed. You know how I know? Because we have tried to measure the height of patients. And in measuring the height of patients to give their predicted body weight, we get a difference of up to 15 centimetres, depending on which of the nurses does it. And that's because in patients lying down flat, it's really hard to measure an accurate height. And 15 centimetres is quite a lot of volume. So nonetheless, we need to try to get a lung protective strategy. We need to use PEEP. PEEP does a number of things for us. It improves our oxygenation. And you can see here on the left, with the application of sustained PEEP, what we're doing is the alveoli are opening up nicely, and then we're ventilating on top of them. With the one on the right, you can see there that the alveoli are opening and shutting. You can see the inflammation occurring within those alveoli. You can feel the ventilator-induced lung injury which is happening. So PEEP is not just there for the improvement of oxygenation, but it's there for the improvement in ventilator-induced lung injury and for the improvement in inflammation at the alveolar level. We know that as PEEP goes up in our sickest cohort, it's associated with improved survival. We know that if we run patients at that higher level of PEEP, it's better. Setting PEEP can be difficult. Many people do a 40 by 40 centimetres of water for 40-second recruitment manoeuvre. And this is what a recruitment manoeuvre does. It opens up the alveoli. And you can see the way that you've gone from a completely collapsed lung, clearly not human, through to, by the time you get to the 40-second mark, progressive opening of alveoli. The problem with this particular manoeuvre is that although you can temporarily open up the lungs doing this or using, say, for example, a bagging manoeuvre, you're not going to be able to set the PEEP. And what you really want to do is to try to titrate the PEEP to the highest level that the patient needs. You can do that through a recruitment manoeuvre. And this is the recruitment maneuver that we would routinely use. So you go continue, same driving pressure, rise up on the PEEP, then come back down. And because of the hysteresis within the lung, you'll find that you open up the lung at a higher pressure than the lung closes. So if you don't open till 18, but you close at 12, you know that you can set it somewhere around the 15 mark to take benefit of that relative pressure relationship. We know that neuromuscular blockade is very important and has improved survival. We know that prone positioning is important. We know that nitric and steroids both improve the numbers but don't necessarily improve outcome to an unselected population. And things such as inhaled and intravenous beta agonists cause active harm, as does oscillation. Either no benefit or harm. What's really interesting in the oscillation story is that if you look between the two studies here, on the left you've got the American study, on the right you've got the UK study. On the left they managed to get 7 mils per kilo in the control arm, and on the right, the Oscar study, they had 8 mils per kilo. And there is a suggestion, albeit it's not statistically significant, but a suggestion that as you come down from 15 mils per kilo down towards 6 mils per kilo, at around the 10 to 12 mil per kilo mark, you're starting to see an equivalence of oscillation with conventional ventilation. It may be that oscillation is better than harmful strategies, but not as good as protective strategies. There is also the question that we don't really know what optimal protective ventilation is. And this was a retrospective analysis of the ARDSNet papers, which looked at the inflection point. And you can see there's a clear change in the mortality after 25 centimetres of water. And it may be that we actually need to bring the pressures down. It may be that we also need to bring down the driving pressures. And this was Amato's work from late last year, looking at driving pressure as it relates to outcome and mortality. Now, of course, it's an observational study. We can't imply causation. It may be that just the stiffer the lungs, the worse the disease, the worse the outcome, rather than the other way around. Nonetheless, it's an interesting signal. And it does make us wonder exactly what's going on in the lungs. So what is going on in the lungs? Well, on the left we have mild disease. We have patients that we see every day. They're on 30-40% oxygen. And you can see the missing bits of lung at the back are where the consolidation is. But the front portion of the lung is nicely aerated. Now, these patients will have 3.5 litres out of their, assuming they're a 70-kilo individual, 3.5 litres of aeratable lung in which to ventilate. So we're using only 11% of their lung volume is being used in our 420 ml tidal volume. By the time we get to this patient in the middle, where you can see you've got far more extensive consolidation, far less lung is available for gas exchange, this moderate problem, you've got 1.5 litres of volume. And we're up to 26% of the available lung capacity because of the heterogeneity of the disease. By the time you get up to the end that we're looking at ECMO for, you've got a tiny little bit of lung there, 280 mils. You're trying to push 420 mils into 280 mils. You can see immediately why we have to have different strategies as patients get sicker, and why lung protective ventilation is not necessarily protective for all patients. The problem is, though, that as we reduce tidal volume down to 4 mils, 3 mils, 2 mils, 1 mil per kilo, we get a steady rise in CO2, which results in acute pulmonary hypertension, right ventricular dilatation, and overall cardiac failure due to the left-right ventricular interdependence. So it's a problem. So this is the population where we need to think about vena-venous ECMO, where we take from the venous side and return to the venous side purely to alter the oxygenation and CO2 clearance of the patient. If we look at the limited evidence, because it is only limited evidence in support of ECMO, what can we say? Well, in the swine flu pandemic, swine flu did the honourable thing and went through the southern hemisphere first, where I came from, down in Australia. Australia, because of virtue of its geography, has a regionalised healthcare system where you have large centres in capital cities and then a very distributed network, because you have to. That's the way the population sits. People are used to travelling 1,000 kilometres in order to access healthcare at specialist centres. That's normal. And as part of that, they used ECMO for the provision of severe respiratory failure, so that A, you could transport people, and B, it was in a specialised environment. What they found was that using that and swine flu, they had an 80% survival. Non-randomized, purely down to clinicians choosing who to put on, but an 80% survival, which had never been seen before in respiratory failure. We then moved on to the CESAR study, which came out at around the same time, which looked at the provision of ECMO in a specialist centre versus the provision of conventional care. Now, it's important to reflect that the CESAR study was not ECMO versus no ECMO. It was specialist centre with access to ECMO versus non-specialist centre without access to ECMO. And some 80% of patients achieved ECMO in the ECMO limb. They found a significant mortality advantage to going to a specialist centre which provided ECMO. And then in the subsequent swine flu pandemic as it hit the UK, those patients case matched, so propensity matched, observational series, 80% survival if you were 25 with swine flu and no comorbidities and went to an ECMO centre, 50% survival if you didn't. ECMO is not necessarily about providing an individual patient who is guaranteed to die with an advantage. It's looking at improving the overall survival. You can't guarantee that the patient you give statins to, it will prevent the myocardial infarction. But you do know that if you give statins to a large number of people, that you will reduce the overall burden of disease. And the same is true with ECMO. You need to look after the patient's lungs, make sure they are sick enough, but what you really want to do is you're not looking at it as salvage therapy in the peri-arrest situation. You're looking to apply it in patients a cohort of patients who will benefit. We've seen a massive rise in the number of ECMO cases which have been done in the world since really swine flu came around, particularly with respiratory ECMO. Who do we need to look at? This is one example. This is a patient selection using the PRESERVE score, and what they found was that patients who were younger, patients who were plumper, patients who were less sick all did a bit better, and that makes sense in general for critical care. It's consistent with the rest of critical care literature. We know that cachexia is bad, age is bad, etc. What's really interesting about the PRESERVE score is look at the bottom half there. Mechanical ventilation for a long duration, not being prone, not having the right PEEP, having too high a pressure, too high a volume. They were the things associated with worse outcome. They are all things that we can correct in our intensive care today. And they found a massive difference between the two groups. So if you take your 21-year-old with swine flu and you ventilate them well, you're looking at a 95% survival, which is what we have. If you ventilate them badly before ECMO, they've got a 50% survival. In the UK, we've developed a system on the back of the CESAR study looking at a specialist model of care where we provide care to about 15 million people. We have strict criteria, early, sick enough. We use the Murray score, and we don't offer it to everybody. If you are dying of something else, you don't get access to ECMO. So if you've got a malignancy, etc., we don't go there. What sort of patients do we have? Many of them have CTs like this, complete hepatization of the lungs by the time we get them onto ECMO. And this is a common thing. But we also offer it to trauma patients, and they can do just as well. This is not artifact, that is a post through the chest, managing to miss every vital organ on the way through remarkably. Pulmonary hemorrhage, often considered a contraindication to ECMO, do very, very well, albeit you need to run them without heparin for a while. The same as intracranial hemorrhage. And these are real CTs in real patients we've had, and they've all been neurologically intact afterwards. 1 in 8 patients on ECMO will have an intracranial hemorrhage at the beginning. Run them without heparin. ECMO gives you advantages in terms of a distributed healthcare system. It allows you to transport the patients. You can transport them by air, by road, by sea, however you wish to do so. We have a physician model, so a pure intensivist model. Our surgeons are delighted to assist, but delighted to stay home and be in bed as well. And that's what they spend most of their time doing at night, whereas we run around the countryside putting people onto ECMO. So we use ultrasound. We use fluoroscopy in order to target. And then, similar to the cardiac program, we're looking at lung rest, identification of the problem, and adequate gas exchange. We have a fixed diagnostic pathway where every patient gets access to CT, everyone gets echo. In my view, there's only one indication for echo, and that's that you've got a heart. If you haven't got a heart, you don't need an echo. If you do, you need an echo. Everyone gets an HIV test, 2% in the UK population have HIV. We do a recruitment scan looking at differential pressures. The patient at the top has significant non-recruitable lungs. The patient at the bottom recruits very nicely. It may or may not help you in terms of the immediate ventilator management, going up to 40 centimetres of water, but it does help you for some of the diagnostics and looking at the lung parenchyma. It can also help to better target your proning. Once you're on ECMO, you need to think about lung protective ventilation. And on this ventilator, that's in litres, so we're talking about a 40 ml tidal volume. Tiny volumes. Step back, rest the lungs. You can also get people up and walking around. So you don't need lungs to exercise. They're not important things once you're on ECMO. So this patient's standing up. This young lady is playing on the Wii. She's just out of shot as her lunch. We can also go a bit further afield. Go and have a little tour of the river, sit by the Thames, look at the Houses of Parliament, watch the world go by. Very useful when you're awake in an intensive care, because they're very boring places, I'm afraid. And you can get up and walk around. Why shouldn't you? Lungs are unnecessary to get up and walk around. So get up, get your patients up. These patients are femorally cannulated. They can be walked around. We tend to put the cannula in a little bit further down the thigh than the groin crease. And you can ride a bike. In this case, this young lady is on the hand cycle rather than the foot cycle, but you can happily ride a bike on ECMO. Why does having a national service work? What is important? It is not just me. Okay, I have a massive team. I have doctors, I have nurses, I have physios, I have perfusionists, I have dietitians, I have speech and language people, but I also have a population of 15 million people. And I'm the primary ECMO centre for those people. As a result, we get volume. Volume we know is important. Volume is really important. Nobody goes to a mitral valve surgeon who does one mitral valve a year. You'd laugh at the surgeon. If they said, I do one a year, I'll happily do yours. You'd say, don't be silly. We know volume is associated. We know that it's associated in cardiology. The more caths you do, the better you get. We know that it's true in ARDS in general, and we also know that it's true in ECMO. And this is data from late last year, looking at the ELSO database with survival as it relates to outcome. So size is important. We do about 120 cases. This was last year's data. Steady rise over the last 5 years in cases. And this is our survival, going from ECMO survival on the left, which consistently is around the 75 to 80% mark, through to hospital survival, ICU survival, sorry, in the middle. There's always a small drop-off, through at the far end to 6-month survival. So these are patients who are back home, not necessarily entirely without problems, particularly psychological problems we see after ECMO. It's a younger patient cohort. But they can do extremely well, but ECMO is only a small part of the package of care with severe respiratory failure. Thank you very much, and please join us in Euro also next year.
Thank you so kindly, Dr. Barrett. Now we take a 5-minute discussion. Questions, please. Mohammed, please.
For Dr. Ghazmouri, you were talking about norepinephrine as not being the ideal solution for circulatory failure. Can you just elaborate further, because it was at the end of the lecture and we didn't get that restructuring of the JAMA results?
Yeah, of course I will acknowledge that I am really in the minority. There's a big push, probably with good justification by the people who propose that, to the use of vasopressors. And I believe if you're going to use a vasopressor, norepinephrine is a good choice. There was a recent study showing that So I said vasopressin, I mean norepinephrine. There's a recent study, the Advantage study, that showed that vasopressin does about the same. My experience at the bedside is the following, that once a decision is made to start somebody on a vasopressor, the order is typically written as titration within certain range to a given pressure. And there's little follow-up after that. Now, a patient who is in septic shock, this is what we're discussing here, it's a very dynamic process. And it's not unlikely that a patient who might have been successfully fluid resuscitated at the beginning may become fluid deficit over time because of the nature of the disease